Good morning, good morning, good morning, and welcome to the Great Lakes Health Radio program on Power 96.5 FM, WUFO 1080 AM. Thank you for listening to our program. Thank you for sharing the comments with me when I see you in the community. I'm your host for this hour, Francesca Messiah, Manager, Workforce Development from Kaleida Health. Before I talk a little bit about Kaleida Health, I just want to say our topic for today is obesity, causes and how we can all overcome obesity. And our guest for today is Dr. Ashley Bernotis. And but before I even talk a little bit about Dr. Bernotis, let me talk about Kaleida. Who is Kaleida? We're the hospitals. Only reason I say this because I know people are still a little confused. We are Buffalo General Medical Center, Visiting Nursing Association, Oshai Children's Hospital, Millard Fillmore Suburban, Gates Vascular Institute, Great Lakes Cancer Care Collaborative, High Point Long-Term Care Center, DeGraff Long-Term Care Center, DeGraff Urgent Care. We also have sites and clinics in several of the Buffalo public schools. We have adult clinics throughout the city and north of the city, south of the city. We also have pediatric clinics in the city, north of the city, south of the city, and I should say in the north towns and the south towns. And we also have women's clinics for OBGYN in Buffalo, outside of Buffalo, to the north of Buffalo, and to the south of Buffalo. We have something for everyone's needs when it comes to healthcare. Back to our topic. Well, the topic today is obesity, as I said, with Dr. Ashley Bernotis. Good morning, Dr. Bernotis. How are you?
Good morning. I'm doing great. Thank you.
Thank you. And Dr. Bernotis, I believe, is relatively new to the Kaleida family. I say relatively new because I've been here for 20 wonderful years. And Dr. Bernotis, have you been here for a year yet?
No, I actually started here in April. My husband and I relocated to the area. I'm originally from Toronto, so we wanted to be closer to family, and I had completed my training out on the eastern side of New York on the Vermont border and decided to move closer to home.
Oh, thank you. And we're just going to go right into the interview. Dr. Bernotis, please describe what is obesity and why is it such it's not a new topic, but it's this emerging topic in healthcare in the nation and in our community. So if you could just say, what briefly is obesity and why is it so important?
Yeah, so I'll preface this with the fact that I am dual board certified in family medicine and in obesity medicine. So this is definitely a topic that I enjoy learning about and teaching others about. So obesity has been long defined as having a BMI greater or equal to 30. The BMI is absolutely not an ideal representation of disease process, as it doesn't take into account fat mass in our bodies versus fat-free mass. But it's been used for decades because it's easily reproducible without requiring expensive equipment. And so far, it's the best we have. Our hopes are to develop something a little more specific that will give a better idea of disease process. And as we know, some patients or some athletes who have a lot of muscle mass may have a high BMI greater than 30 and not actually have a very high percentage of fat mass on their body. And so finding ways to discover a better way to define obesity is in our future. So basically, obesity is defined as the abnormal or excessive fat accumulation that presents a risk to our health. It's definitely become a hot topic in the healthcare community, as we've been noticing a steady rise in obesity rates over the past years. And what's very concerning is that U.S. projections are estimating that over half of the U.S. population will have the disease of obesity by the year 2030. This is only 6 years away. It's definitely an epidemic. It needs to be addressed. And our bodies were just not meant for the way that we live now. Our bodies are traditionally made for being hunters and gatherers, active 12 hours a day, not for the more sedentary lifestyles that we live now. And so we're finding a difficult time processing the foods that we're eating and exercising enough to really burn the calories that we are taking in throughout the day.
That is excellent overview of obesity and 12 hours a day and hunter and gather. And that's just, we're not doing that anymore. But something you mentioned, and it ties into the next question. You said you are dual certified and you mentioned family medicine. So when it comes to family, obesity, and genetics, is obesity genetic? Can it run in the family? Sometimes people will say, well, my mother was big boned. My father was, is there such a thing? Is it genetic? So is it something that can obesity run in families? Does it run in families?
Absolutely. So the answer, the easy answer is yes. It is a chronic disease that has genetic components. We've even uncovered some epigenetic components. So epigenetics is a study of the environment that we were born into. So the environment in which our mother lived in and while we were in her womb, essentially. So the stressors that your mother encountered while pregnant, the amount of sleep she got, whether she was smoking, whether she was drinking, that all influences us now as it imprinted on our genes. So there's research being conducted to identify specific genes that contribute to obesity. We've already found some that contribute to a slower metabolism. So the fact that one person can eat the exact same thing as another person and not gain weight or gain a lot more weight than the other person definitely has a genetic component because our metabolism has a genetic inheritance as well. So that's why you can look at family members and identify, oh, maybe I got such and such a side of the family's genetics or such and such, and that's really, we take that all into account when we're researching this. And the future of the genetic part of this is great because it'll allow for even more targeted treatment plans and medications that will be more specific to patients and will work better on some patients than others.
That's excellent. And I always have to talk about careers. And for anyone listening to this show who's interested in becoming a physician, a nurse, a physician assistant, you can just spend your entire career, which I think would be fascinating, researching genetics. You can just focus on genetics and obesity. If this is a career that you think that you might be interested in, this would be this would be a career. And I just had to add that because I always like to talk about careers. Obesity and overweight. Is being obese and being overweight, is that the same thing?
So no. Well, technically one leads into the other, but overweight, we use the archaic definition of BMI again, overweight is defined as a BMI ranging from 25 to 30, and obesity is defined as a BMI equal or greater to 30, and that is just the traditional way of defining it. But essentially, being in the overweight category generally flows into the obesity category, especially if it's developed early on, such as in childhood or adolescence. We'll often see that if you had any inkling of being overweight, then as our metabolism slows, as we age, as our hormones shift and change, we tend to shift into the next category, which is obesity.
Yeah, and I know there's a listener too who wants to, and it's not a call-in show, but I know there's a listener too out there who wants to ask you, could you just define what is a BMI?
Yeah, so BMI, in an easy way of describing BMI is it's a mathematical calculation that takes into account your height and your weight. And you don't necessarily have to know the formula, but it comes up with a number that places you in a category based on your height and your weight. And so that will put you into either an underweight, a normal weight, an overweight, or an obese category. Like I said, it's not perfect. It doesn't take into account fat mass versus fat-free mass. I've had some patients who have a BMI of 33 and they have 7% body fat because they're a personal trainer, they're doing competitions. And so technically, according to the world, they are obese or they have the disease of obesity. But really, we know that with a fat mass of 7%, they are definitely not in the obese category. So again, not a perfect indication, but it takes into account your height and your weight, and it's often measured at all your doctor's office visits. So if you're interested in your BMI, you can just simply ask your doctor's office or look on your sheet, your progress report from your previous visit. You can also go online and just search BMI and input your information with your height and weight, and it will give you a calculation of that.
Okay, thank you. Does having extra weight on one's body place the internal organs in jeopardy?
Yes, so there's a certain type of fat that encapsulates the organs, and it's known as visceral fat. It is known also as toxic fat. It's actually the worst type of fat you can have in your body. Within our body fat, we have different categories of fat, and I won't delve too deep into that, but basically visceral fat, the one that wraps around your organs, is the worst. So it can affect the heart, and it increases the risk of heart disease, which can lead to stroke or a heart attack. It can also affect the blood vessels, where it can cause high blood pressure, which can damage blood vessels over time and increase the risk of heart attack and stroke. It can also affect the kidneys and the liver and lead to fatty liver disease, that non-alcoholic fatty liver disease. So a fatty liver caused by non-alcoholic causes is on the rise, actually. And it could also affect the gallbladder, leading to gallstones and inflammation. And we know that over time, inflammation in the body can lead to certain types of cancers. It can also affect the bones and joints. So the more weight you carry, the more pressure there is on your joints, which can cause arthritis over time and reduced activity levels, which in turn make it more difficult to exercise and to shed that weight. And then maybe one of the most important, well, they're all very important, but I would say the brain. The brain, fat accumulation in the brain can increase the risk of dementia, including Alzheimer's disease. And we're having a lot of discussions around dementia and Alzheimer's disease and how it comes about. And they're finding that fat deposits in the brain are really affecting that. So all of these reasons, if anything, to get some treatment and help in reducing your fat mass.
And just so you know, Dr. Bernotis, I have already put part 2 because we're going to have a part 2. This is just the entry conversation. I've already marked little things where I'll be calling you back. We're going to do another program on some of these things that you have mentioned, fatty liver and all these other things. So, listeners, hang in there. In a few months, we will have a part 2 to get into detail to what some of these areas really are, because they are fascinating. So from about 20 years ago, let's say 20 years ago, and I'm just going to say 20 years because that's how long I've been with Kaleida. And I remember when the obesity clinic, or I forgot the name of it. It is not called obesity. It is called, what is it called? Weight loss?
It's called, no, we've actually just rebranded it, so renamed it. So it's called the Kaleida Health Weight Management Center. And it's a comprehensive center, and I'll explain that in detail. Actually, I can explain it now. So it's a comprehensive center, if you don't mind, I guess.
No. It's the next question. That was my question, which was, we've discussed, the services and how have over the 20 years, the Weight Management Comprehensive Center, how has, like, what it was, and in your background from 20 years ago to the services now. So it's all about talking about the services that we provide.
Yeah, so basically, it's come a long way, which is exciting. It's finally defined as a chronic disease. So I tell patients, just like you may have high blood pressure, you may have diabetes, you may have asthma. These are all chronic diseases, and obesity is just one of those chronic diseases. Sure, are there factors that we can modify on our own in order to improve this? Absolutely. The same can be said about high blood pressure and asthma, but we should be treating it like a chronic disease, just like any, to reduce the stigma around it. It's not simply all on the patient in order to fix this. There's so much more complexity to this disease. So I would say that over the last 20 years, there's been an increased awareness and understanding of obesity as a complex, multifactorial condition. So having multiple reasons for having the disease of obesity, like I discussed earlier, with the genetics, with your environment, with your socioeconomic status and your access to food. And it's not just simply a result of poor lifestyle choices, which for years patients were just told, oh, well, just eat less and exercise more and you'll get—
Take
and
out the carbs.
Yeah. And,
Right.
and I mean, how many, at what point you should not have to exercise for 4 hours a day in order to be at a healthy weight,
Right.
and that tells us that there's something else going on there. There's something else, the patients will come to me and say, I barely eat anything, and of course that's not good either, because we have to get our metabolism running. But is there something that we can tweak in order to rev up that metabolism and help them going? It's help get them going. So there's so much more to it. We've also, over the past 20 years, expanded treatment options. So we have these wonderful medications that come close to bariatric surgery results. So for instance, bariatric surgery gives you about a 20 to 30% weight loss. And the medications can give up to 20% weight loss without having to go under the knife. Of course, some patients will need bariatric surgery. We know this. And some people will use the medications, but the medications have come a long way. The medications also help in other ways as well, in terms of decreasing sugar, helping your cholesterol, helping your blood pressure, helping your thyroid disorder, and reducing certain types of cancers, which is pretty incredible. There's also, with the reduction in the stigma surrounding obesity, there's been a stronger emphasis on behavioral therapy and counseling. So programs that incorporate what we call as CBT, which is cognitive behavioral therapy, they help patients discover maybe why they have these unhealthy eating habits. Do they have a history of trauma? Do they have a history of PTSD? Do they resort to food as a comfort? All these things are not necessarily within our control, and they require additional treatment. I would say that the services have increasingly adopted a personalized treatment plan. So like at our center here, we treat every patient individually. Everyone gets their own individual nutrition plan with their macronutrient goals. So that's your fat, your protein, and your carbohydrate goals, and your calorie goals, because your goals will not be the same as your neighbors or your sisters. I would say that now treatment for obesity isn't relying on one doctor alone. Like I mentioned before, the integration of behavioral interventions and nutritional counseling and exercise, physical activity. We've been growing these teams, and that's essentially what we're doing here at Kaleida Health Weight Management Center. Is we currently have an in-house dietitian who works with you on figuring out what types of foods you eat on a regular basis, and how can we make some modifications in order to make that a healthier diet for you. I don't like the term diet. I think that I refer to diet just as nutrition, because I don't really believe in these fad diets. I believe in overall changing your nutrition so that you can just choose the foods that you enjoy, but in a healthier way. And we work with patients on that here at the clinic. We are also, as we are new, and I only started here April 1st, we are looking to add a psychologist to our team to do the cognitive behavioral therapy and to help patients work through some emotional eating or perhaps some trauma that may lead to eating habits. And we are going to be adding a health coach or a personal trainer to help guide patients in their exercise journeys. As we know, everyone's different. Everyone has different limitations, different disabilities, and they could all benefit from an individualized approach to exercise.
Or different abilities, as I call it, instead of disability. And I know we are running out of time, but I just want for you to go back and let people know what is it, only because I'm like when people hear say acronyms, I know I might know, you might know, but I want to make sure our listeners know PTSD. What does that mean?
So that is post-traumatic stress disorder. We can tie a lot of what we call, I guess, what is traditionally called disordered eating, but just eating habits, I would say, to finding comfort in situations that we may have experienced that were not so pleasurable, especially as children. So if you have a history of trauma, you know, you've had some kind of trauma in your life. A lot of people tend to cope with food. It's comforting. It makes us feel good. If it didn't make us feel good, we would not progress as a society. There's an inborn, there's an inborn mechanism that makes food appealing to us in order for us to survive as a population. And if it wasn't appealing, we just wouldn't eat, right? And so we tend to go back to food as a coping mechanism if we've suffered from trauma. And so many of my patients, I can actually unravel some trauma within their lives that have maybe contributed to not so great eating habits.
Mm. What are some? Because I think we have about 7 minutes left or so. What are some frequently asked questions that when people come into, because I tell, so first of all, I know I want to talk about behavioral, about the counseling. Is it for the family? That's going to be all part of part two, because we are going to have a part two or part three on this topic. But what are some of the frequently asked questions that you hear often as individuals or families are coming in with their loved ones to find out more, to learn more, and where to begin? So I just want you to talk about some of the frequently asked questions.
Yeah, so where can you find us? So that would be one of the most common questions we would get is currently I'm located in Buffalo General Hospital. We will be expanding our services to the north towns, to Williamsville, and our office will be up at the corners of Maple and North Forest Road. We're expecting to be up in there early in 2025, but if our patients contact our office here and get enrolled as patients, we will notify them when we are going up to the north towns. And I will be there most often, but I'll still be seeing patients down here at BGH downtown. So our phone number is 76859-1168. And we are working currently on updating our website, but you can find us on the Kaleida Health website currently under weight loss. It will be under weight, actually, I think it will be by the time this airs, under a new heading called weight management. So if you go to the Kaleida Health website and you search for weight management, you should find our new website and the information in order to contact us. So that's primarily one of the biggest questions. The other biggest question is my insurance going to cover the visit? So yes, we accept all insurance types, government insurance, including Medicare, Medicaid, Fidelis, as well as commercial plans. We accept all insurances because we are part of Kaleida Health. So we accept any insurance that Kaleida Health will accept. And another question that I get a lot is, am I eligible for the new medications? Can I get these new medications that we hear about? So the mainstream medications are Ozempic and Wegovy, and they've made their name for themselves with the celebrity community. But most importantly, Ozempic is generally used for the treatment of diabetes. It is used for the treatment of diabetes, and Wegovy is used for weight loss in patients without diabetes. And summarizing, can you get the medications? Yes, we can work with you and your insurance companies on being able to get the medication. So another frequently asked question is, can I get the medications? So we submit the medication through to your insurance. Your insurance will then determine, is it available for you? Is it not? Which is unfortunate right now, but that is the reality in which we live. Because without insurance, these medications can be very costly. They can be over $1,000 a month. Now we have alternative options for patients whose insurance does not cover the medications, and I can discuss those with patients at their visit. We also, we don't just center around medications. We work with, like I said, exercise and nutrition recommendations. And we also have surgery as a wonderful option. Surgery has come a long way. It's safe. Our surgeons have done these surgeries for years, and they're very good at them. And so we always offer those to our patients as well.
Oh my gosh. Oh my gosh. So just a quick question. This is a frequently asked question. So if you go off the medication, either the Ozempic or the, what's it called? Wegovy?
Yeah.
Wegovy. Will you automatically begin to gain all your weight back?
So I wouldn't say that you're going to gain all your weight back. Now, the studies are somewhat early. These medications, the medications themselves in other forms have been around for years, except they've only now been really delving into the world of treatment of obesity with these medications. And so we have limitations with our study data because we don't have many years of treatment. And but what we're finding is that they are recommended for life. Now, like any medication, if you want to come off of them, I'm sure you can come off of them. We could follow you along, and if you notice that your hunger cravings are coming back, that your eating habits are not are heading back in the wrong direction, and that you're gaining weight, we could always try to get you back on the medications. But I'm sure there's more research to come with that. I don't exactly know how much weight you would gain back. I think it's patient dependent, much like bariatric surgery. We know that if you have the surgery, it's not guaranteed that you're going to keep that weight off for life. It requires a little bit of work, and sometimes we actually help patients with these medications as well after surgery.
And Dr. Bernotes, on that note, I'm going to say thank you so much for being our guest on part 1, because there will be a part 2. So in the next few days, I will be checking your schedule again to be the guest on the Great Lakes Health Radio program, because we've only begun to we barely touched the surface on a very important topic, which is weight loss, which is obesity, and your life and the life of and how to improve, your treatments through our Kaleida Health Weight Management Center. So I want to say thank you so much for being the guest this morning on the Great Lakes Health Radio program. And hold on, everyone. Part 2 will begin momentarily. And now on to part 2. You might ask, who is Kaleida Health? Because I still get that question in the community. Kaleida Health represents the hospitals being Buffalo General Medical Center, Gates Vascular Institute, Oshai Children's Hospital, DeGraff Medical Park, Millard Fillmore Suburban. We were also part of the Visiting Nursing Association, the VNA. We also have 2 long-term care facilities, one at DeGraff in North Tonawanda, and the other one in both Buffalo at the corner of High and Michigan Avenue. We have clinics for men, for women. We have specialty clinics for women who are expecting. We have family planning, for targeting more of a younger audience with questions about family planning and such. We are also in schools. We have school-based health centers where we are located in the Buffalo Public School System. And we also have a great relationship with UB, the Jacobs Medical School. And I think this is probably the first time I've mentioned that relationship, because our guest for today is Dr. Lisa Jane Jacobson, and she's a professor with UB Medical School. Also, I would like to mention that Kaleida Health is hiring. If you go to our website, type in your search engine, Kaleida Health, KALEIDA HEALTH /careers. And when you enter that into your search engine, you'll find hundreds of jobs available. Some you just need a high school diploma or a GED, and other positions require further education. But we definitely invite you to apply for a job, and please join our family at Kaleida Health. We need you. Well, our topic for today, speaking about the UB Medical School, and I think most of our listeners are aware that the University of Buffalo has had a medical school, and I'll let our guests share with us how many years. But a few years ago, the medical school moved off the Main Street campus and now located at the corner of Main and High Street. And so they're right in the middle or at the border of the Buffalo Niagara Medical. I would say they're at the border of the Buffalo Niagara Medical Campus, because once you walk down High Street, you'll see all kinds of buildings in Carlton Street. But the medical school is there, and they're doing some very exciting things, engaging community, engaging the community to learn more about their health and to be comfortable with their primary, for you to be comfortable with your primary healthcare physician. So I'm going to introduce our guest, and our guest for today is Dr. Lisa Jane Jacobson. Dr. Lisa Jane Jacobson, how are you?
I am doing great. And thanks for the invitation to come talk with you today, Francesca, to talk with your listeners.
Thank you. And Dr. Jacobson, not only is she a physician, she also has her master's in public health. She is also the Associate Dean for Medical Curriculum in the Office of Medical Curriculum at UB Medical School, along with Associate Professor and Vice Chair for the Education Department of Obstetricians and Gynecology, which are a couple different areas we could talk about. However, today we are talking about the UB Jacobs Medical School, their new curriculum, which is an exciting topic. So Dr. Jacobson, can you just share a brief history about UB Medical School? And besides providing medical services, has the medical school always had a relationship with the community?
Sure. I actually came to Buffalo about 7.5 years ago now. So I haven't been here for decades, but the university has had a medical school since, well, before it was a university, right? Back in 47, I think, when they started the school, and it was right next to Buffalo General, where that was its location way back when. And then about 100 years later, it moved down to what we call the South Campus, with all those the other health profession schools were all centered around there too, on that Main Street campus that you had mentioned. And it wasn't until just very recently in 2017 that we moved here to the downtown campus location, and that large, tall building that everyone has probably seen got built. It's a beautiful building with a huge atrium. If you have not been there, we would love our community to actually visit and see what this, and be part of this school, and come in and come to some of the activities we offer. But it is a really nice facility. And the reason that they built it was, well, the old facility was getting a little too old, and we needed more updated, a place for students and faculty and all the researchers who are doing research in medicine. And so we also wanted to be near the hospitals so that it could become a real hospital, a community, an academic healthcare, community. We'd be close to the Kaleida facilities, and our students and our faculty could go back and forth and easily go from the school to the hospitals, et cetera. And all work together a little bit more closely. It made it easier to collaborate.
Has a medical school always had a relationship with the community before moving into the community?
So I can't speak to all of the decades, past, but, you and I talked recently about it was about 40 years ago when Dr. Maggie Wright had, who was a previous associate dean for student affairs at the medical school, had developed a program where they were teaching medical students about the importance of, working in the community, understanding the health problems of the community and issues related to equity. And I'd have to say that legacy has absolutely continued. And it's probably, I think, the strongest it's ever been right now at the school, because we've had programs that have been similar. And I'm sure her programming led to this course that we have called Health in the Neighborhood, where students actually work in the community and learn with families. They have host families, and they learn about health issues with the community, in the community. But and they learn how to do their physical exam and all of that stuff by training by people who work in the community. They anyway, those kind of programmings has been around for a bit, but now everything is expanding. And we realized that some of these programs really needed to be further emphasized. And our new curriculum that we've been developing is going to be working very hard to make some of these, to work on some of the issues that are, troubling our community and impact the health of the people here in Buffalo. Our curriculum is going to address it directly.
And I remember a few years ago, being part of the community, working along with you. Maybe that's when we met at the meeting where you were asking community about the curriculum, and you were explaining to many of us different who worked at the time, worked in hospitals or not-for-profits. What would a curriculum look like? So could you tell us, how has a curriculum changed? What was it, and what's the new?
Well, as part of the new curriculum, we realized, everybody I'm sure out there can imagine that, doctors need to know about science and understand why diseases happen. And they have to learn about treatments and procedures and medicines that have to be, given to help treat things. But what a huge part of medicine is understanding people, right? And understanding the people that, we treat. The understanding people's perspectives on their own health and what they want for treatment, everything from barriers that might prevent them from being able to even come in for care or do some of the treatment options that we kind of discuss with them. And understanding all that is really important. And as well as understanding the health system and how doctors are going to be playing a role in the health system, and how patients, how does the health system affect whether they can even get care? So those are things that we've infused into the curriculum now, because everyone needs to be able to know that and learn that. So, one of the things that's really important, we have what we call a thread that will kind of go throughout the entire curriculum, the 4 years of medical school. But it was actually started with the leadership of the late Dr. Jonathan Daniels, who was a beloved human being, physician in our community, and many may know him.
Yes, he was a great man.
A tremendous man. And he passed away about a year and a half ago. But he started the Muse curriculum with a wonderful team of collaborators, and they're working extremely hard to make sure that legacy stays alive and that this program will flourish in the new curriculum. But it's the Muse program. He was a muse for everyone, right? He was a inspiration, somebody who made everyone, it was a thought leader. And that's sort of what I think a muse is, somebody who inspires others. And it stood for medicine, understanding, social equity. And that curriculum is being developed, and it's part of this anti-racism and health equity thread that will be running throughout the whole curriculum. So students who come in from the very first course that they take in the first few weeks are going to be understanding and learning about some of the things that impact people's health care here in Buffalo, including social structural determinants of health that get in the way of people being able to be as healthy as they should be, and obtain the care that they want to, and even trust the system of care, and how, how it impacts them, and how they interact with the system that we have, the healthcare system in general. So that's one example. And you asked about, how do we get involved in the community? Well, we will be implementing something called learning communities, and every Wednesday or every other Wednesday, our learning communities groups, which are smaller groups out of the 180 students, they're going to be groups of 6 with a mentor. They're going to be actually going out into the community and doing something called Community Connect, where they're going to be working in organizations for every other Wednesday afternoon here in the Buffalo area, in order to sort of understand more about our community, understand some of these organizations and what they do to help people in the community, and actually getting a chance to get to know people as human beings, so that when they see them as patients, they have a connection. They understand a little bit more. Their world has been widened about, how people live, and what our community is like. So that Community Connect program is important to us too.
And Dr. Jacobson, along those lines, and I know you said that the students are going out to the community, and I'm sure everything's in place. But have you ever thought about having a couple of the groups held in the med school? Because UB Medical School is always such a mystery. It's like only smart people, if you're good at math and science, go in that building. So I don't know if you've ever thought about hosting a couple of the meetings at the med school, plus, encouraging people to bring their families, because it could be that start for that person who thinks it's a big mystery. It could be for that person who may want to develop an interest in science or major in medicine, because if you're going out to the community, you won't know about what's going on in the inside. And to me, it's a beautiful building, and it's not a mystery.
Yes. And, I'd have to say our new dean, she's been now with us a year and a half or 2 years, even maybe now almost. But she actually has made this real strong initiative to use our building, for more community events, because there's a real strong, desire to get people to come in and see what we're doing here. And again, make it so that it's not, a place that people don't feel comfortable in, or that they wonder what is inside that big, huge structure that's in their neighborhood, But, I think a lot of the programming that I see happening is with kids. So, our surgery department has a great drone STEM program where our local high schools kids are brought in, and they have their T-shirts made, and they compete doing surgical skills and using laparoscopic instruments. And I'll tell you, those high school students are able to use laparoscopic instruments better than some residents I see training. But they learn it very quickly. It's almost like because they're so used to games and video games too with their hands, but they pick it up so fast. And they also learn how to steer drones around. And it's basically a program that helps, kids who are interested in science and technology, engineering, careers, healthcare. They kind of it inspires them. So that's one of the programs, but they also bring students in for something called Camp Cardio, where there's a week-long camp to learn about heart health. So there are a bunch of different programs that occur, mostly with bringing children in. The Girl Scouts, they bring the Girl Scouts in too to work with them during the year. But I bet more adult programming would be useful. I think it's a wonderful, wonderful idea.
Yeah. Now, when they go out into the Community Connect, and I just have to mention Dr. Daniels. Just when you mentioned Dr. Daniels' name, I still get a little teary-eyed, but because he was such a great man, and his family, they're great. But okay, so with Community Connect and going out and meeting with the community, and I know it's the medical students interacting with community. Do they also, by chance, as part of this new curriculum, speak with community about being comfortable with speaking with their physician, meaning do they even teach them medical jargon so that they understand? A lot of times a physician will speak to you. You don't necessarily understand, but you don't want to admit that you don't know what the vocabulary is. And do they interact with the community and helping them develop a comfort level in speaking with a physician?
That's an important goal for sure. And hopefully some programs like Community Connect will make people, just having conversations makes you understand, the best ways to converse and the best ways to explain things and talk with folks and understand them better. So I think that kind of experience will translate. They'll bring that into the, outpatient clinic or the exam room when a person comes in. They'll kind of have they'll be more comfortable talking to folks in language that people understand. And I know that you and I, as we spoke, it's been a year or more, with various community groups. And Dr. Mecca, who has been leading this curriculum revision with me, was involved very intimately in doing a lot of this outreach. One of the main topics was always, the relationship between people out there in the community and the doctors and the healthcare providers, and some of the things that made it hard for folks to come in and feel comfortable coming in to get care. And also some of those, those barriers of, well, I can't necessarily understand what they're saying. They don't quite get me. They don't understand what's feasible for me, what the life I live and why I can or can't do what they're telling me to do, that would be good for my health. And then just like you said, speaking in language that normal people, not medically trained people, can understand is really important. Because if somebody leaves, the office and doesn't understand what happened and doesn't understand what's going on with their health, and they can't be a part of their own, their own care. Like they want, I'm sure patients want to do their part of it in the process too. But if they have to understand it. And then a plan that makes sense to both sides has to be created, right? It has to be good for the patient and the provider. In order for it to work. So yeah, we do stress that. It's actually part of that Muse curriculum that I mentioned, that, learning how to address folks in a way that's, understandable. And in our foundations of patient-centered care, where our students are going to learn about how to take medical histories and such things, that will be very much stressed. That whole communication aspect will be really emphasized.
And then even just making sure the patient understands why that medical history is important. Because some things you go into and it's routine, but does someone know that if they've gained a lot of weight, or if they've lost a lot of weight, or if their blood pressure is high, what disease it could possibly lead to. So, it's not a matter of, again, that one-way communication. It's just trying to have that, having that individual, that the community understand why keeping their body, not to say keeping it in good shape or maintaining, but going to your provider is like tuning your car. Like you don't go 10 years without taking your car in for an oil change, or you shouldn't, So just so they begin to understand their own importance. Why good health is important, but I think that's great. The Muse, medicine, understanding social equity, and social determinants of health. I call it many times social determinants of life, because many times you can't separate one from the other. What else would you like to share with us about the new curriculum?
Oh, well, there's so many things, but, I think we had to revise the curriculum. We're making big changes because, the world moves on and life changes, world changes, and health problems change. And so we're incorporating a lot of these things too, and trying to address the very, the wonderfully diverse population that we have now in this world, and especially here in our community in Buffalo. We need to make sure our students are coming away really knowledgeable about what are those things that affect our community in particular, but and beyond. So from the very first, 3 weeks of school, they're going to be learning, about 5 real significant societal problems that are affecting us here. But what we'll be doing is, doing it in a slightly different way than in decades past. I mean, understanding in a holistic way what kind of things, it's not just the basic science behind it. It's not just the medical treatments of how to, fix things, but what are those other humanistic aspects that kind of, affect people's health and affect whether they can get health care and be treated well and improve their health. And then we mentioned health system science, and also even things like how do people understand information that's out there, and what do you trust and what do you not trust? When it comes to medical information, and we call that scientific literacy and inquiry. So we want our students to kind of understand how do you figure out what's really good information and what's not. And these are some of these pillars that we're kind of infusing into the curriculum so that they understand that it's not just understanding science and treatments, it's also understanding people that will make them a good doctor. Because you don't have that, nobody's going to come to your office, and you're not going to be able to achieve the outcomes that you want to achieve, which is improving people's health. So that's really an important component of our new curriculum.
Yeah, and I know that we only have about 2 minutes left, but that's what caught my eye, that scientific literacy and inquiry, because when I saw that, it just reminded me of culturally why sometimes African Americans can be, don't necessarily trust medical community with some of the different studies, and not only Tuskegee, we hear about that, but the Lacks woman, I can't think of her first name, but I know Lacks. Henrietta Lacks, and just so but the students understand that, and they don't just say, oh, well, that was a long time ago, but no, it did happen a long time ago, but that distrust is still there. So at least listening to the patient, understanding that, to build trust, because to me, it's all about building trust with your primary care doctor, and the doctor building trust with their patient. Yeah. So, any closing comments? Because can you believe we're almost at the end? Any closing comments?
That will go so quickly. Just that we would love to share our school, our curriculum, our students with this community. And we're so thankful that the community has begun to embrace our students as well, and allowing them to come into their organizations and learn. I think 75% of our doctors here in this area trained at one point at UB, whether it's in the medical school or in the residency. So those are the folks that are providing healthcare to us all. So we want to make sure that we're doing it right, and that we are developing, a training program, a curriculum here, and medical school training that will provide the best, graduate the best doctors who will be able to provide care for this community going forward for the decades to come. So anyway, those are our efforts, and we would love any community help people who want to get involved. There are many different ways to do that. So anyway, thank you so much for allowing us to talk today.
You're welcome. And how would they get involved? Do you have a phone number or email address?
Yeah. If they are honestly interested in figuring out ways, they can reach me by my email, even directly, ljacobs@buffalo.edu. And we'd be happy to figure out how we could get people involved.
Okay. Well, thank you so much, Dr. Jacobson. and who also teaches aerobics. I had to throw that in.
We believe in health and wellness, so.
Yes.
And you were a great participant, Francesca.
Yes.
Enjoyed having you in class.
Thank you so much. And I just want to say, listeners, in 2 weeks, or I should say next week, you will be hearing from my esteemed colleague from ECMC, and that is Mrs. Bass. And in 2 weeks, God be willing, you'll be hearing from me, Francesca Messiah, Manager, Workforce Development, Kaleida Health. And I hope you've enjoyed listening to our program today, because we sure have enjoyed you listening to us. Bye-bye.